Hello, this is the chemical pathology of the liver presented by Dassi SchrDbb. We reference chemical pathology lecture notes of University of Cape Town. This part of chemical pathology notes was written by Dr. Reed and Dr. Harley. So now we are going to start with the liver structure. So with the structure of the liver, we are going to know, you need to know that what blood supply to the liver is going to be based on the hepatic artery, which is going to supply 25% of the liver blood flow, and then you have the portal vein, which supplies 75% of the liver blood flow. Now, among the portal veins, you have one that comes from the gastrointestinal tract, that's going to take nutrients, toxins, and bacteria. One that comes from the spleen, which contains bilirubin, because the spleen is one of the reticuloendothelial system for the breakdown of red blood cells, and one from the pancreas, which contains insulin and glucagon. Now, this is generally that. Now you need to know that what anastomotic connection between the systemic and the portal circulation is going to exist. You need to know that the portal circulation and the systemic circulation is going to exist as an anastomosis at the level of the periumbilical veins because of the ligamentum, because of the ligamentum teres forming from the artery. So these periumbilical veins are just derivative of the umbilical vein. The next we have the lower esophagus from the left gastric vein, and we have the rectal vein. This is why every time somebody has a liver cirrhosis, meaning that there is a congestion of the portal circulation. Since the portal circulation does not continuously flow, there is going to be backflow into systemic circulation. That's why in liver cirrhosis, in chronic liver cirrhosis, some patients are going to have carpal medusae, which are just carpal medusae are distended abdominal veins. Is it clear? You have lower esophagus. At the level of the lower esophagus, you're going to have also things like esophageal varices, and at the level of the rectum, you have things like hemorrhoids, but hemorrhoids is less likely associated with liver cirrhosis. Now, the venous drainage of the liver is there the hepatic vein, and it's going to enter into the inferior vena cava. The general does it. Now, for the architecture of the liver, you need to know that the liver is divided to form the hepatic globules, and for you to know more about it, you just go on our tutorial on histology. So generally, just like in histology, this is the general structure and the architecture of the liver, showing the structure of an acinus. Is it clear? So the liver has two main sides. It has the apical side and it has the basolateral side. At the apical side, and it has the basal side. At the apical side, you have blood flow. So you need to know that what the liver cells are directly in contact with the red blood cells. Why? Because the red blood cells are inside sinusoidal capillaries, which have a very large hole of such that the liver cell can directly be in contact with the red blood cells. Is it clear? All the blood. And also you need to know that at the basal side of the hepatic cells, we have the bile drainage by bile canaliculi. Is it clear? So generally that's that on the structure. So for you to know better on the structure, it's better to go on our tutorial on histology. Generally, you need to know that there is centrilobular. It means that blood comes from the periportal circulation. Blood is going to come from the periportal circulation, from the portal triad. Is it clear? The portal triad is made up of the bile duct, is made up of the hepatic artery, and is made up of the hepatic portal vein. Is it clear? So this blood is coming from the hepatic portal vein. This blood is coming from the hepatic artery. So all of that is going to pass from the periportal part of the acinus to the mediolobular part of the acinus to the centrilobular part of the acinus. Is it clear? So generally, if you have a certain molecule which is toxic and has been taken from the portal circulation, the first people that are going to die and that are going to be shown on biopsy are going to be the periportal circulation. And that is why if you want to know higher on it, it's better for you to go on our tutorial of histology. The next is the metabolic function of the liver. Now, the metabolic function of the liver, you need to know that the liver play a role in carbohydrate metabolism, in lipid metabolism, protein homeostasis, in glycolysis, the Krebs cycle, gluconeogenesis, and all that. Is it clear? Those are the main role. And now you need to know that the liver is also going to play a role in certain major metabolism, such as bilirubin metabolism. So you need to know that the source of bilirubin is going to be via hemoglobin, because of the breakdown of hemoglobin. Red blood cells are going to be 90% of red blood cells are broken down. It's going to occur at the reticuloendothelial system, and mainly that's going to occur at the level of the spleen. Now, you have to note also that hemoglobin can also be produced at the level of ineffective erythropoiesis in the bone marrow. You have other sources of hemoglobin. You need to know that the red blood cells, the bilirubin, 75% of bilirubin comes from hemoglobin, while only 70 to 80% of bilirubin come from the breakdown from hemoglobin, while 20 to 25% come from myoglobin and the other heme-containing substances. So these other heme-containing substances are myoglobin and cytochrome P450, which are going to be broken down at the level of the liver. Now, this is going to be the formation of bilirubin. Now, let's work on it. Generally, you need to know that bilirubin is going to form after the hemoglobin has been broken down. Hemoglobin is going to be broken down to produce heme and globin. And globin, now, you need to know that generally hemoglobin is made up of a single heme molecule, and is made up of 4 globin chains. The globin chains are either the alpha globin chains and the beta globin chains. Is it clear? So generally we have the 3 globin molecules there like that. The alpha globin chains is because it is made up of the alpha sheet, while beta globin chains because they are a beta plated sheet. Is it clear? Generally that is that. Now you need to know that what the alpha and beta globin are just going to enter inside. They can either be converted to glucose for gluconeogenesis, or they can go into glycolysis, or they can be converted to fat, or they can be converted to proteins. But what is of main importance is the heme. Now the heme is going to be converted first to biliverdin. Is it clear? That's why it's going to, the bar is going to be more sometimes greenish. Is it clear? Biliverdin. So you need to know that what this is going to occur after the combination of oxygen to produce carbon dioxide by this enzyme here, and this enzyme is going to be the biliverdin reductase. Is it clear? So no, the biliverdin reductase act at this level. So the one which acts here is a microsomal heme oxygenase, or you can just say biliverdin synthetase. So it's going to synthesize biliverdin, which is this molecule. Now the next step is that inside the liver cell, we are going to have the conversion of biliverdin into, inside the liver or any reticuloendothelial system. We are also going to have the conversion of biliverdin into bilirubin after the use of biliverdin reductase. So here is biliverdin synthetase, and here is biliverdin reductase that's going to produce now bilirubin. Basically, so here you are going to use NADPH for the release of hydrogen into this part here. And you can see the different molecules here. Now after that, you're going to produce this bilirubin. This bilirubin is also called unconjugated bilirubin, or is also called free bilirubin. So it is hydrophobic, so it's capable of dissolve. It is fatty and fat soluble. Basically, that's why it's called hydrophobic. Hydrophobic means that it is phobic means that you are afraid of. So hydro means water. It is afraid of water. It does not soluble. It's not soluble in water. So it's strongly bound to hydrophobic side on the albumin. So that's why it's really transported with albumin. Now you need to know that free unconjugated bilirubin normally should be less than 3 milligram per deciliter, or less than 3 micromole per liter. Is it clear? For the unconjugated bilirubin, it should be less than 3 micromole per liter, and can be displaced from albumin by drugs like salicylate or sulfonamide. That's why generally it is not good to give children sulfonamide drugs, because it can displace the albumin. Is it clear? And certain example of sulfonamide, you have or even sulfonamide. You have certain example of sulfonamide. that you can use. You have pyrimethamine, sulfadoxine. Sulfadoxine is an example of a sulfonamide, which can cause a displacement of the bilirubin from the albumin. Is it clear? So generally, it's not good to give sulfonamide to children who have malaria. Now we have the next one. You have free unconjugated bilirubin is also neurotoxic because it can bind at the level of the basal ganglia to cause kernicterus. That's why every time a child has a neonatal jaundice, you are always scared of that, because there are many complications of neonatal jaundice that can result later, and among which the first complication is going to be kernicterus. Other long-term complications, you have things like teeth. You are going to have yellowish discoloration of the tooth. Those are other complications that you can have. Now, the next is that, so you have to know the uptake by the liver. So you need to know that unconjugated bilirubin is only going to be uptaken by the liver. Is it clear? So after albumin transporting it to the liver, it's going to be uptaken by the liver via carrier mediated process, and inside the liver they are going to be having conjugation. So conjugation is going to occur when the liver cells are going to because the liver cell contain the UDP glucuronil transferase enzyme, which is going to transfer now the glucuronil subgroup to the bilirubin, and that glucuronil now the UDPG glucuronil is, so bilirubin is going to be converted. You see that the UDP glucuronil transferase form to bilirubin monoglucuronide and bilirubin diglucuronide. So you have the conversion of bilirubin to this, which bilirubin monoglucuronide and bilirubin diglucuronide, having the glucuronil subgroup. Basically, such that you need to know that what these are now molecules are called now conjugated bilirubin. Now conjugated bilirubin now is water soluble, so it's capable of being excreted in urine, it's capable of being excreted in bile and all that. Is it clear? So generally that's why the body wants to produce it. Now the excretion of bile. So the excretion of bile is mostly made up of conjugated bilirubin. Is it clear? And then it's going to be excreted into your gastrointestinal tract. When it's excreted in the gastrointestinal tract, you have certain action on the gastrointestinal. You need to know that some of the bilirubin is going to go back into circulation via the enterohepatic cycle. Now some of the bilirubin, conjugated bilirubin, is going to be acted upon by bacteria of the body to produce urobilinogen, which is going to be converted to urobilin. The two is going to be converted later to urobilin, and that's going to enter into circulation to stain urine and make the urine to be yellow. And also some of the bacteria in the large colon are going to act on the bilirubin, on the conjugated bilirubin, to produce acrobial that is going to stain your feces yellowish. So generally this is how bilirubin metabolism occurs. So the bilirubin metabolism, it starts with hemoglobin, the red blood cell, which is broken down to produce globin and heme, and then the heme is going to be broken down to produce iron, which is going to be stored in the body via ferritin and bilirubin. Now this bilirubin is free or unconjugated bilirubin. Now the bilirubin is now going to bind to the liver cell via certain receptor mediated cycle transport. Then bilirubin enter is going to be converted via the UDP glucuronil transferase enzyme to first monoglucuronide bilirubin and diglucuronide bilirubin, which is actually conjugated bilirubin, and then can be lost now in via the bile to the gastrointestinal tract. Now in gastrointestinal tract, you have certain bacteria that are going to act on it to produce urobilinogen, and urobilinogen is going to be reabsorbed in the body and then can be secreted in the urine. And also now in the large, that's why that occurs in the small intestine. In the large intestine now, you're going to have the production of stercobilinogen by bacteria in the large intestine. Is it clear? And the bacteria in the large intestine producing stercobilinogen are going to result to the pigmentation of the feces. So that's it. So generally you need to know that 20% of urobilinogen is reabsorbed in the small intestine after its production, and you can visualize urobilinogen at the level of the dipstick. Now you need to know that a patient that has a conjugated, if you have a patient that has jaundice, and you want to know that the jaundice is more conjugated bilirubin or unconjugated bilirubin, we can use the urine dipstick. Is it clear? So the urine dipstick can see urobilinogen. You need to know that urobilinogen is produced from conjugated bilirubin. Is it clear? Since urobilinogen is produced from conjugated bilirubin, you need to know that there are three forms of jaundice. The jaundice can either be pre-hepatic, it can be hepatic, or it can be post-hepatic. Is it clear? Those are the three main types of jaundice, as you're going to see later. Now, in post-hepatic jaundice, you need to know that there is obstruction of flow of conjugated bilirubin in the gastrointestinal tract. Since conjugated bilirubin does not enter the gastrointestinal tract, we have no production of urobilinogen. So you are going to have no urobilinogen inside urine. Is it clear? That's why the urine dipstick is going to be negative of urobilinogen. So if you have a urine dipstick which is negative of urobilinogen, you can think of a post-hepatic jaundice. So in that case, there is an accumulation of conjugated bilirubin in blood. Is it clear? Now the next case is in the case where you have a patient that has pre-hepatic jaundice. For pre-hepatic jaundice, you have high level of unconjugated bilirubin. So high level of unconjugated bilirubin is going to produce high level of conjugated bilirubin, is going to produce high level of urobilinogen. So the high level of urobilinogen is going to be secreted in urine. Is it clear? So in this case, it can make you think that the patient has a high level of, in this case where you have a very high urobilinogen in urine on dipstick, you can think of a high unconjugated bilirubin due to a pre-hepatic jaundice. Now the next one is a bile acid and a bile salt metabolism. You need to know that the source of bile acid is going to be soluble metabolite of cholesterol. Usually they are produced from cholesterol. The formation of bile acid, you need to know that the product of cholesterol metabolism are choline-deoxycholic acid. Usually they are just called cholic acid from cholesterol, cholic acid. So we have cheno-deoxycholic acid and we have also cholic acid, which are primary bile acids because of their hepatic origin. The rate limiting step of this reaction is via this particular molecule, via the formation of the 7-alpha hydroxylation of the cholesterol. Now you need to know that prior to the secretion into the bile canaliculi, the primary bile acids are going to be conjugated by the glycine and the taurine molecule. So at first, the ones that are produced by the hepatic cells are going to be the cheno-deoxycholic acid and the cholic acid. Is it clear? Now, but before now they are secreted, because you need to know that for you to be present inside the bile, you need to be water soluble. Is it clear? But this one here, cholic acid and this cheno-deoxycholic acid and cholic acid are not soluble much to water. Is it clear? So you need to be attached to glycine. Is it clear? Or taurine. Is it clear? When it's attached to glycine and taurine, it's going to be more soluble. So that one is going to be called conjugated bile acid and not conjugated bilirubin. You have now conjugated bile acid just like conjugated bilirubin, which can be transported now to the biliary canaliculi. Is it clear? Now in the gastrointestinal tract, you need to know that you have bacterial enzyme is going to deconjugate and the alpha dehydroxylate of the primary bile acid. Is it clear? Such are going to be converted now to secondary bile acids called litocholic and deoxycholic acid. Is it clear? Now most of the bile acid in gastrointestinal tract is reabsorbed now in the portal circulation. Is it clear? And taken in by the liver again and re-excreted in the enterohepatic cycle. Is it clear? So that generally that is what you have to know. So it's just the same cycle like the bilirubin. So just like bilirubin, it's going to be produced, it's going to be transported to the liver as be the primary, like its primary bile acid. Is it clear? That one is going to transport to the liver and produced also by the liver cells. We have cheno-deoxycholic and cholic acid. So it can just be called unconjugated bile acid. Now unconjugated bile acid, for it to be to be released now into bile, is going to become conjugated after having the addition of glycine and taurine. When it's conjugated now, it can be released now via bile now to the gastrointestinal tract, where the bacteria are going to act to produce the secondary bile acids, which is going to be lipocholic acid and deoxycholic acid. And later on, you're going to have enterohepatic cycle, where there is a reabsorption of the lipocholic acid and the deoxycholic acid back into the bloodstream, and then which is going to be reuptaken by the liver such that it can be released again. Is it clear? And you need to know that there's a very important role of the bile acid. This bile acid does not need to be secreted. Why? Because it is helping you. The bile acid is helping in order to emulsify the fats. Is it clear? It increases the surface area for the action of the fatty enzymes. Is it clear? Like bases. You need to know that generally when you eat food which contain fat, and when you drink water, you are going to have a reduced surface area, because the fat is hydrophilic and the water is hydrophobic. Is it clear? The fat is hydrophobic and the fat is hydrophobic and the water is hydrophilic. So what's going to happen is that they are going to oppose each other. Is it clear? So the fat is going to produce micelles and all that, and that's going to reduce the surface area of the fats for the enzyme action. So bile acid now can come into place such that it can increase the surface area for the enzyme action on those fats, and then you can absorb fat into your body. Now, circulation of the bile. So generally this is the diagram where you have it. From cholesterol, you have the 7-hydroxylase enzyme that is going to convert now to produce the different cholic acid and cholic acid. Now this cholic acid now can be bind either to glycine to produce glycocholate acid, or to taurine to produce taurocholate acid. So now the next one is circulation of bile acid. So you need to know that what if there is obstruction. So you need to know that but normally it needs a small fraction is going to escape reabsorption by the liver and appear in the systemic circulation. So for the circulation of bile acid, you need to know that if there is obstruction in the biliary tree, there's going to be back pressure and there's going to be reflux of bile acid from the liver directly back into the systemic circulation. That's going to cause a constant systemic bile acid concentration with a side effect of causing pruritus, because you need to know that those bile salts can cause itching sensation in the body. So if there is also congestion, it's not only conjugated bilirubin that is going to accumulate at the level of the systemic circulation. Also, bile acid is going to accumulate in the systemic circulation, and the side effect of bile acid is that it can cause you to have itching sensation. Now, the next thing is that if there is liver damage, is it clear, at the level of this one now is intra-hepatic. So if there is liver damage with impaired reabsorption of the bile acid from the portal circulation, more bile acid than normal is going to appear in systemic circulation after meals. Is it clear? So here you see that the liver is damaged, so the liver is not going to, so normally the bile acid is going to be produced from the system, from the portal circulation, but the liver is not going to secrete it back into the liver is not going to secrete it back into the bile canaliculi. Is it clear? So you're going to have accumulation also. And if there is also ileal disease, bile acids are secreted and not reabsorbed, and resulting to a constant low systemic level. So in case of ileal disease where bile acids is not reabsorbed in the enterohepatic system, you're going to have very low level of bile acids in blood. So this type of patient are not going to be capable of reabsorbing easily fats. Is it clear? Now the structure of bile acid, this is generally the structure of a bile acid here. Is it clear? This is the hydrophilic portion of the bile acid, and this is the hydrophobic portion of the bile acid. So you see that bile acid has two main portions. It has a portion which is hydrophilic and hydrophobic. Now when these two portions is capable now of causing emulsification of fat. You see, just like soap, when you use when you have a fatty, when you have a plate, you realize that what a good example is that when you have a plate with fatty meal and then you try to put water on it, is it clear? You realize that the water molecules are going to be like droplets. Is it clear? So they are going to be like droplets. You see that the fat and the water is completely going to be dissociated. Just imagine that state of fat and water being completely dissociated in the gastrointestinal tract is going to be very bad. Is it clear? It's going to be very bad because they are not going to have any absorption of the fat. You need to have the fat inside the water for you to reabsorb the fat. Is it clear? So now bile acid is going to act just like the soap inside your stomach. Is it clear? So it's helping to just like the soap inside your gastrointestinal tract. So you see that when you take down this plate having fat and water droplet together, which are going to be separated, when you put soap in it, you realize that the fat, the water and the fat become combined together in one homogeneous mixture. Is it clear? That's the similar action of bile acid. So bile acid is just going to combine to produce that similar homogeneous mixture between the fat and the water, so that you can easily reabsorb it. I can also help in cleaning the gastrointestinal tract. You can just think it as being a soap of the gastrointestinal tract. Why? Because it contains both a part that is going to bind to the water with the OH bond, the hydrogen bonding, and also contain a part, the hydrophobic part, that is going to bind now with the lipid part. Is it clear? So the function of bile acid is that it's going to solubilize cholesterol for excretion, also solubilize dietary fats for absorption, stimulate bile formation and flow. Now, what are the biochemical tests of the liver cells and function? The most important liver biochemical test of the liver is going to be liver function test. Is it clear? So the liver function test is made up of three major entities. The first thing is going to be the bilirubin level. The second thing is going to be the prothrombin type, and the third thing is going to be the albumin level. So it helps you to know if the liver cells are actually functioning or not. So bilirubin is usually measured by the Gendrasic growth modification by Van den Berg reaction. Is it clear? So conjugated bilirubin is also called direct bilirubin. It's also called direct bilirubin because it's going to have direct reaction, while unconjugated bilirubin is also called indirect bilirubin because it's going to have indirect reaction in the Gendrasic growth modification. Is it clear? So that's why you also call conjugated bilirubin the direct bilirubin, because the direct bilirubin is going to do a direct reaction in the Gendrasic reaction, and then you have the unconjugated bilirubin is going to be also called indirect because it has an indirect reaction. Now the normal total bilirubin is going to be less than 17 micromole or less than 3 milligram per deciliter. So normal urine contain no bilirubin. Normally urine does not contain any bilirubin. No conjugated bilirubin is found there. What is found inside urine is normally urobilinogen. So no bilirubin should be found in urine, since unconjugated bilirubin is albumin bound. Is it clear? And it's not filtered. Now you need to know that bilirubin only appear in urine when conjugated bilirubin is elevated in the plasma. It's only when conjugated bilirubin is elevated in the plasma that the conjugated bilirubin can appear in the plasma. So you are going to have high level of conjugated bilirubin in the plasma in the urine in case where you have post-hepatic jaundice. So when you have a post-hepatic jaundice, you're going to have high level of conjugated bilirubin in urine. Is it clear? But when you have a case of high level of urobilinogen in urine, it means that it is more of a pre-hepatic jaundice. Now, increased amount of unconjugated bilirubin are found in the plasma. You are going to have increased bilirubin because of increased bilirubin. When you have increased unconjugated bilirubin, it's mostly due to pre-hepatic. So you are going to have increased bilirubin production, that is hemolysis from the spleen or intravascular hemolysis or all that. You're going to have decreased uptake or conjugation. So when you have decreased uptake or conjugation occurring in the case of a hepatic diseases, and we have in generalized hepatocellular dysfunction also. Basically, when the hepatocellular dysfunction because cannot reuptake the unconjugated bilirubin. So we have other specific inherited syndrome like the Gilbert syndrome. You have the Klinger-Naegel syndrome. Now the Gilbert syndrome is a syndrome whereby there is an we have jaundice in this patient, and the cause of this jaundice is because the patient cannot reuptake unconjugated bilirubin in the liver cells. That's Gilbert syndrome. Now, Klinger-Naegel syndrome is a syndrome. It's divided into two. We have Klinger-Naegel syndrome type 1 and Klinger-Naegel syndrome type 2. Is it clear? In Klinger-Naegel syndrome type 1, generally with Klinger-Naegel syndrome is a problem with conjugation. Is it clear? Generally, it's a problem with conjugation. The unconjugated bilirubin cannot be converted to conjugated bilirubin because of the lack of the UDP glucuronidase transferase enzyme. In Klinger-Naegel syndrome, generally can be divided into type 1 and type 2. The type 1 is involved also with inability of reuptake of the unconjugated bilirubin in the hepatic cells plus inability to conjugate, and the type 2 is also associated with inability for the hepatic cell to excrete the bile into the biliary canal. Now those are the different syndromes here. Now the next one is that you can have increased amount of conjugated bilirubin. The next is that you can have also decreased excretion of bilirubin. Is it clear? So decreased excretion of bilirubin is going to much more occur in case of high level of conjugated bilirubin in blood. So you have conjugation, but the conjugated bilirubin cannot be excreted into the biliary canal. Is it clear? So high level of conjugated bilirubin can be due to an obstructive liver disease, in a case where you can have a carcinoma of the head of the pancreas or you can have any cholestasis function. So when you have accumulation, you have any cholestasis, is it clear? So you can result to that. Now the next, you have a hepatic. So you need to know in specific, you have also specific rare inherited syndrome like the Rotor syndrome and the Johnson syndrome. The Rotor syndrome is a syndrome where you have a disorder, both of them. You have a disorder of the transport of the bilirubin of the conjugated bilirubin from the hepatic cell into the biliary canaliculi. For the Rotor syndrome, the biliary canaliculi, normally in the biliary canaliculi you are going to have cilia. So in order for you to beat the bilirubin out of the biliary canaliculi, so in the Rotor syndrome, this ciliary system is not working again. While in the Johnson syndrome, there is inability of the hepatic cell to excrete bilirubin into the biliary canaliculi. So this is the urobilinogen that I've just said. So it can help you to measure different bilirubin. So as I've said, I've said that urine bilirubin is going to be increased when you are going to have a high level of pre-hepatic jaundice. Is it clear? When you have high level of unconjugated bilirubin, because high level of unconjugated bilirubin produce high conjugated bilirubin, that's going to be disintegrated at the level of gastrointestinal tract to produce more urobilinogen. That's going to make the dipstick to be more positive for urobilinogen. So when you have a high level of urobilinogen, think of a pre-hepatic jaundice. Now for the liver enzymes, the liver enzyme is not actually a liver function test. Liver enzymes can tell you more of an liver enzyme mostly tell you of an acute inflammation of the liver. Is it clear? Why the liver function test tells you more of a chronic disorder of the liver, so that the liver has lost its function. Now the liver enzymes, generally you need to know that it is useful to know that there is an acute inflammation of the liver, because acute inflammation of the liver is going to result to the destruction of the hepatic cells and the release of the enzymes in the hepatic cells into blood. Is it clear? Now enzymes reflecting liver cell damage. So the enzyme reflecting liver cell damage, you have the first one, the transaminase. Generally, you have two transaminases. You have aspartate transaminase and you have alanine transaminase. Aspartate transaminase has widespread tissue distribution, including the liver, the red blood cell, the skeleton, and the cardiac muscle. So it does not only say that it is the liver that is being destroyed. So no tissue-specific isoenzyme. Is it clear? Now, also, alanine transaminase. So aspartate transaminase is more widely distributed, while alanine transaminase is more specific to the liver. Is it clear? So when you have alanine transaminase, it means that it is more specific to the liver. It is going to increase. Now, the next enzymes that is also involved is lactate dehydrogenase. You need to know that lactate dehydrogenase also has a widespread in the liver, the red blood cell, skeletal muscle, cardiac muscles. Is it clear? And it has different isoenzymes. You need to know that the isoenzyme that is specific for the liver is the LD5 isoenzyme of the lactate dehydrogenase. So the next one, you can have other enzymes like alkaline phosphatase, has a widespread distribution now. Now you need to know that alkaline phosphatase is particularly present in the bones, also in the placenta and GIT, particularly in the bones. It tells you that there is high destruction of the bone cells. When there is high destruction of bones, you are going to have high level of alkaline phosphatase in blood. Is it clear? And can also tell you that there is liver destruction. So the natural function of the enzyme is unknown. Is it clear? Now the next one is gamma glutamyl transferase. Is it clear? It's more specific also to the liver. It involves the transport of amino acid across the liver cell plasma membrane. The serum level is going to increase in the case where a patient is going to have cholestasis, or when there is a case of excessive alcohol intake, barbiturate intake, phenytoin intake. Is it clear? Particularly in cholestasis, because I say that cholestasis, when there is accumulation of bile, when there's accumulation of bile, it is shown by three major biochemical molecules. The first major biochemical molecule is going to be raised bilirubin. The second is going to be increased gamma glutamyl transferase, and the third is going to be increased alkaline phosphatase. Those are the three major molecules that tells you that there is cholestasis, and they're going to increase proportionately. Now, while in the case of alcohol consumption, you just have an increase in gamma glutamyl transferase without any increase of alkaline phosphatase, no bilirubin. Now, the next one is plasma proteins. So you need to know that the plasma protein is another. So these enzymes were not actually liver function tests. What is another liver function test are the plasma protein, particularly albumin. So the liver is going to synthesize plasma protein except the immunoglobulins, as you have already seen before. So you need to know that albumin is going to decrease in the case of a chronic liver disease. The clotting factor is going to have a short half-life in the case of chronic liver disease. So you need to know that clotting factor have a short half-life. Particularly, you have clotting factor 7 has a half-life of 4 hours. Prothrombin time is also known as the international normalization ratio. Is it clear? The partial thromboplastin time (PTT) may be prolonged in the liver disease due to a decreased intensity of the clotting factors. Is it clear? And that decreased intensity of the clotting factor may be due to a primary disease of the liver, or it may be due to a secondary disorder where you have a vitamin K deficiency, or also with a fat malabsorption. Now the immunoglobulins. Now the immunoglobulins show generalized increase in chronic liver disease. When you have a chronic liver disease, in order to make sure that the plasma protein should be maintained at a proportionately normal level, the immunoglobulins are going to increase in order to compensate the loss of the other plasma proteins which are produced by the liver. Now in primary biliary cirrhosis, you're going to have immunoglobulins GM is going to be more increased, is it clear, in order to compensate, because the immunoglobulin M's are the one that is more dense. Is it clear? So when you have biliary cirrhosis, you are going to have more immunoglobulin M. In alcoholic cirrhosis, immunoglobulins A are going to increase. So all these are liver diseases. Is it clear? So when you have a biliary cirrhosis, it is more of immunoglobulin N that is going to increase. When you have alcoholic cirrhosis, more of immunoglobulin A. So A for alcohol. Is it clear? A for alcohol cirrhosis. When you have an autonomic chronic active hepatitis, in case of an A hepatitis, you have more of IgG that is going to be present. Now alpha fetoprotein is an embryonic form of albumin. Is it clear? So albumin in the child is going to be more of alpha beta proteins. Normally it's going to be absent in the plasma and it's increased markedly in primary liver cell carcinoma and hepatocellular carcinoma or hepatoma. Is it clear? That's when you see alpha fetoproteins most likely. So now the alpha antitrypsin deficiency is a genetic disorder which is associated with emphysema. You need to know that every patient that has this alpha 1 antitrypsin deficiency usually will have emphysema because trypsin is going to react excessively. When trypsin reacts excessively, it's going to result to destruction of the liver and also result to destruction of the lungs. Now the question is that why is it that trypsin is going to be you need to know that, as I've said, is that what I've said that the pancreas has both the endocrine and the exocrine system. Is it clear? And then the endocrine system is going to secrete these chemical substances inside the gut, while the endocrine system of the pancreas is going to secrete these chemical substances inside the blood vessels. Now sometimes the chemicals from the endocrine exocrine system of the pancreas constituting of trypsin, which is used in digesting protein, can enter into blood and going to be transmitted. Is it clear? When it's entering into blood, it can result now to destruction of different tissues in the body. Every tissue that contains protein is going to destroy it. That's why they say role now of the alpha 1 antitrypsin now to neutralize this trypsin. Is it clear? So when you have an alpha 1 antitrypsin deficiency, they are going to have two major destructions. The question is, why is it that the liver and the lungs are the major structures which are destroyed? The liver and the lungs are major structures which are destroyed because the liver and the lungs are the highest storage organs for the blood. Is it clear? Liver and lungs are the highest storage organ for blood. Is it clear? So the liver is going to be destroyed first, because blood coming from the pancreas first go to the liver by the portal circulation. So that's why you have childhood cirrhosis, and then the lungs is going to destroy it later because there is high pool of blood inside the lungs. Is it clear? Resulting to severe emphysema, and this emphysema in this case is going to be more of peripheral. Is it clear? It's going to have a peripheral emphysema than a centrilobular emphysema. In cases of smoking, you have centrilobular emphysema more in patients who are smoking, and you have peripheral emphysema more in patients who are having this alpha 1 antitrypsin deficiency. You have ferritin also is going to be stored in iron and stored at the level of the liver. So increased level is going to show that the iron store. You have liver cell necrosis. Is it clear? Now the next one is plasma ammonia. Now the normal level of ammonia should be less than 40 micromoles per liter. You need to know that when you want to break down proteins, ammonia is going to be released. Is it clear? And it should be less than this. Now hyperammonemia occur in the case of a generalized liver disease. Now the question is why. You need to know that the liver is helping. You need to know that normally ammonia should not increase its value because ammonia is toxic for the body cells, but ammonia is produced by all the body cells in the body when they break down proteins. When you need to know that when ammonia reaches the liver, that ammonia is going to enter the CoA cycle, and the ammonia is going to bind with carbon dioxide to convert into urea, and urea is less toxic and can be secreted into urine. Is it clear? Now we are going to have a patient with hyperbonemia in case where the CoA cycle cannot function, cannot occur again. In case where you have a generalized liver disease with hepatic failure, you are going to have a transient hyperammonemia only in newborn because they have only a liver immaturity. Now the urea cycle enzyme deficiency. That urea cycle enzyme deficiency is the one that is happening in the CoA cycle. So this mostly present in childhood with neurologic symptoms. Is it clear? And the diagnosis of hyperammonemia is going to be made. You need to know that generally when you have high level of ammonia, it's going to be the major cause of the hepatoencephalopathy. Is it clear? High level of ammonia is a major cause is a major way by which the liver affects the brain. Is it clear? So the liver is going to affect the brain when there is a liver failure resulting to a high level of ammonia, and high level of ammonia can now go at the level of the brain for the synthesis of more glutamine. Is it clear? And glutamine now is a neurotransmitter that is going to increase the activity of the brain. That's why patients that are going to have it are going to have things like flapping tremors. Their brain is going to increase in activity, and that is hepatic encephalopathy with different stages. Now, the CSF glutamine is going to increase in the case of hepatic encephalopathy, as I have just said, because of this ammonia, because it's going to convert glutamic acid into glutamine, and glutamine is going to increase the the activity of the brain. Now, liver disorder and jaundice. As I have said, jaundice is divided into pre-hepatic jaundice, where you have excess production of the bilirubin. You have intrahepatic jaundice, where you have decreased uptake of bilirubin, decreased concentration of bilirubin, and decreased excretion of bilirubin. And you have post-hepatic jaundice, which is biliary obstruction. Now, for pre-hepatic jaundice, what are the disorders? Everything that can result to hemolysis is going to cause pre-hepatic jaundice. You have things like infections like first malaria. Malaria can cause that. Is it clear? Other infections like leishmaniasis can result to that. Is it clear? Now, you have abnormal hemoglobin. Now, if you have a patient that has a hemolytic disorder with abnormal, you need to know that generally you have inherited hemolytic disorders. For you to cram easily the inherited hemolytic disorder, you have to draw the red blood cell. You have to draw the structure of the red blood cell. The structure of the red blood cells, you have the cell membrane first. The second is that inside the cytoplasm, you have the hemoglobin. The next, inside the cytoplasm, you are going to have the ribosomes. We are going to have the enzymes. And then the next is that you have the nucleus. So generally that is, so you have no nucleus in the red blood cells. So you first have the cell membrane, then you have the hemoglobin inside the cell, the cytoplasm, and then you have the enzymes. So now, generally, you need to know that what on the cell membrane you have the red blood cell membrane defect, like hereditary spherocytosis. Is it clear? It's a disorder that is going to cause hemolysis based on the cell membrane. Now, based on the hemoglobin, you are going to have sickle cell anemia. You have also thalassemias, which is going to be based on the hemoglobin. Now, based on the enzyme defect, we have GCPD deficiency, glucose 6-phosphate dehydrogenase deficiency, or you can also have pyruvate deficiency. Now, others, you have autoimmune hemolytic anemias. Is it clear? So autoimmune hemolytic anemia, which are IgM mediated or IgG mediated autoimmune hemolytic anemia. Now also others, now you have blood group incompatibilities, where you have a fetal to maternal blood transfusion, and also blood transfusion with abnormal blood group. You have bacterial toxins causing hemolysis, and you have malaria, infections like malaria and leishmaniasis. Now, ineffective erythropoiesis and those other infections like bacterial toxins. The bacterial toxins, particularly the toxins from Shigella toxins, and also the toxins from Escherichia coli. You have enterohemolytic Escherichia coli is also going to produce Shigella-like toxins. All of them are going to cause hemolysis, which is going to cause hemolytic uremic syndrome. Now, the next is that you have ineffective erythropoiesis. In ineffective erythropoiesis, you are going to have megaloblastic anemia. Now, the result of laboratory testing, laboratory test in case of excess bilirubin, you can have increase. So I'm not going to speak about that because I've just said it. So intrahepatic bilirubin. Now, the causes of intrahepatic bilirubin, you have specific causes which are rare, like Gilbert Syndrome. I've said the Gilbert Syndrome is an inherited disorder where you have decreased expression of the UDP glutamate transferase due to transmission. So mildly increased level of unconjugated bilirubin. Is it clear? So though the Gilbert syndrome is more associated with the receptors at the level of the cell membrane, is it clear? Though you have some form that is more because there's low level of the UDP GT1. Is it clear? When there's low level, because this is going to produce now bilirubin monoglucuronide. Is it clear? That UDP glucuronate transferase 1. Now, Klinger-Najdorf syndrome is divided into type 1 and type 2. Now, both of them are autosomal recessive Gilbert syndrome. So it's autosomal recessive disorder, and now there's a mutation with the UDP GT1. It means that the glucuronate transferase 1 has a disorder, is absent, leading to an absent glucuronate transferase 1. So we are going to have more unconjugated bilirubin. Now, in Klinger-Najdorf syndrome type 2, here you are going to have an autosomal disorder where you have the glucuronate transferase 1 with a mutation of glucuronate transferase resulting to still a reduction in that. Is it clear? But in case of Klinger-Najdorf syndrome, it's also called Area syndrome, is going to be milder than the type 1. So type 2 Klinger-Najdorf syndrome is milder than type 1. Is it clear? So it's only mild mutation. Why this is severe mutation in Klinger-Najdorf syndrome type 1. So defect in excretion. When you have the defect in excretion, can be the Dubin-Johnson syndrome, you can have Water syndrome. So this is a benign inherited disorder where you have an increased conjugated bilirubin in the serum. Is it clear? Conjugation occur normally because of him, so it's going to occur normally, but there is going to be increased conjugated bilirubin because of decreased excretion. Now let's speak of acute viral hepatitis. Now you need to know that what there is importance. So you need to know that. So this is a very common infectious disease worldwide, and the causes of acute viral hepatitis, generally the causes of acute hepatitis are hepatitis A and hepatitis B. They are the commonest cause of acute hepatitis. You can have also non-A, non-B hepatitis, which can be due to they can be non-A, non-B hepatitis. Now generally you need to know that hepatitis C does not cause acute hepatitis but only chronic hepatitis. Is it clear? Hepatitis D does not cause acute hepatitis. It's only going to cause fulminant hepatitis, mostly when it's going to occur with hepatitis B. And hepatitis E can also cause acute hepatitis, and it's similar to hepatitis A. Now, other hepatitis virus has no serologic test available yet. You have hepatitis F, G, H, other hepatitis virus. And now the next one is the other viruses can also be involved, like Epstein-Barr virus and cytomegalovirus. Now, clinical feature of hepatitis is going to be generally divided into 3 phases. You have pre-ecteric phase, where you have flu-like symptoms like nausea, vomiting, diarrhea, abdominal pain. Is it clear? In acute hepatitis, now 2/3 of the cases never develop to produce jaundice in the case of ecteric phase. So this is an anecteric or subclinical hepatitis. You cannot easily diagnose hepatitis in the pre-ecteric phase. You can diagnose any other disease. Now in the ecteric phase, now you have tender hepatomegaly, you have jaundice, you have dark urine because of high level of bilirubin and high level of urobilinogen, and you also have but in this case you don't have in this case you don't have whitish or pale physics because there is no obstruction. What you can have is that you can have severe intrahepatic cholestasis. Is it clear? In this patient, you can have cholestasis. Why? Because you need to know that what hepatitis is when you have hepatitis, you're going to have a form of a hepatic. When you have hepatitis, you're going to have a hepatic hyperbilirubin, and that hepatic hyperbilirubin is going to result from the fact that there's high level of cholestasis. Is it clear? This high level of cholestasis means that the hepatic cells are not going to excrete again very well. Is it clear? So that's why you're going to have pruritus in this patient. You can have also pale stools, and you can have steatorrhea. Is it clear? And now that dark urine can come from high level of conjugated bilirubin, but not too much urobilinogen. Now in the recovery phase, you have prolonged lassitude and you have different depression. Now what's the outcome? In uncomplicated cases, the resolution can occur most of the times by the patient himself, so he knows he does not need any medication. Now massive hepatic necrosis is going to result to liver failure and is going to have a high mortality, and then the progression can also result to a chronic hepatitis. So those are the different fates of hepatitis. Now in the pre-ecteric period, it can resolve. In the ecteric period, it can resolve. Why can also in the ecteric period can result to chronic hepatitis, or which can result to hepatitis, cirrhosis, which can result to hepatocellular carcinoma. Now you need to know that what it is only hepatitis C that is first going to result to cirrhosis, then result to hepatocellular carcinoma. Is it clear? Why hepatitis B can directly lead from chronic hepatitis and go to hepatocellular carcinoma, or go from chronic hepatitis to cirrhosis. Generally, hepatitis B does not move from chronic hepatitis to cirrhosis or hepatocellular carcinoma. When there is that progression, you think of hepatitis C. Now, you have massive hepatic necrosis. You have dirt, you can resort to dirt, and then you can also resolve. What are the biochemical features in hepatitis? Generally, in hepatitis, you don't have an abnormal liver function test because it's acute. So the bilirubin may be increased. So you are going to have mixed picture of hepatocellular dysfunction and obstruction also. So you need to know that you are going to have increased unconjugated bilirubin. Is it clear? In this case, the patient is going to have an increase in unconjugated bilirubin. Why? Because there is hepatitis, and so the liver is not going to conjugate again very well the bilirubin. So you are going to have both an increase in unconjugated bilirubin and you have an increase in conjugated bilirubin, especially due to the obstructive phase, because it's an obstructive phase as you have seen in this icteric period. But now you need to know that what, so this is a mixed picture, but generally you need to know that the conjugated bilirubin is going to be generally much more than the unconjugated. So the urine is going to be both positive with bilirubin, and that bilirubin is going to be conjugated bilirubin, and also positive for urobilinogen. Is it clear? So in this case, just telling you that what, it is both the conjugated bilirubin that is increased and the unconjugated bilirubin which is increased. Is it clear? Because I've said that when you have bilirubin in urine, it means that it is conjugated bilirubin which is high, and when there is urobilinogen in urine, it means that it is unconjugated bilirubin which is high. So this is a picture of both in a hepatitis, when you have a hepatic bilirubinemia. We said that what bilirubin, when you have a intrahepatic high level of bilirubin, it can either be due to one, an abnormal absorption of the unconjugated bilirubin into the hepatic cell. It can be two, an abnormal conjugation, or it can be three, an abnormal excretion. So you see that the hepatitis is going to add all of them. Is it clear? So when you have addition of all of them, it's an addition of the pre-hepatic and post-hepatic jaundice. Is it clear? So that's why you have that in hepatitis. You have both bilirubin which is high and urobilinogen that is high. Is it clear? An increase is due to reuptake of urobilinogen by the liver. Is it clear? And then you need to know that what, if intrahepatic obstruction develop, urobilinogen is going to disappear. So now, the more the intrahepatic obstruction is going to develop, like in the case of a cirrhosis, the more it's going to convert to a chronic hepatitis to produce a cirrhosis, the more you're going to have urobilinogen in blood reducing. Is it clear? So acute hepatitis is going to be more of both severe and clinical picture mixed together, but you are going to lose the clinical picture of pre-hepatic in case where it is converting to a chronic hepatitis, because chronic hepatitis is going to associate with liver cirrhosis, and in liver cirrhosis the cells are going, because you need to know that when the liver cells are destroyed, they will grow again. Is it clear? But they will grow in an abnormal picture. Is it clear? So it means that after, when you have an acute liver cirrhosis that has passed and has converted to a chronic, when you have an acute hepatitis that has passed and converted to a chronic hepatitis, it means that the cells have died, but they are going to grow back. Is it clear? So in this case, the patient is going to have a normal cell functioning. Is it clear? It means that they are going to conjugate their bilirubin and all that, but the excretion is going to be abnormal because the architecture of the liver has changed. Is it clear? So in this type of patients, when they have liver cirrhosis, you have a loss of picture of the urobilinogen. Now, acute inflammation markers are going to be shown also, particularly ALAT and hazard. You are going to have early and dramatic rise in the serum transminase, reflecting that the hepatocyte damage. Is it clear? It can reach to 20 to 100 times the upper limit. Now, in massive hepatic necrosis, the transaminase may certainly decrease due to total destruction of the liver cells. Now, so when you have a very low level of transaminase, it's very bad because it's a very poor prognostic factor. Alkaline phosphatase and gamma glutamine are not greatly elevated. This one are going to mostly be elevated when you have cholestasis. So when you have intrahepatic cholestasis, that you have these two which are elevated. Now the plasma proteins. So you have that. And now the plasma protein generally means to know that albumin has only a slightly decreased is going to slightly decrease in acute because it has a long life cycle. But the immunoglobulins, you have early increase, you have IgM, and lately you have IgG. You have decreased prothrombin index. In the epidemiology, you need to know that when hepatitis and infectious disease, generally for hepatitis A, to make a diagnosis of hepatitis A, can use the hepatitis A virus antigen. You can use also for a current infection, can use hepatitis A virus immunoglobulin antibodies, and for a current or previous exposure, you have hepatitis A virus IgM. As we have said, we said that IgM is produced primarily, while this is going to be produced later. Now, hepatitis B, you need to know that there are going to be different antigens on hepatitis B. You have the surface antigen, the envelope antigen, the core antigen, and each of these antigens have different antibodies. So when you see hepatitis B surface antigen, it means that the patient is infected with hepatitis. Is it clear? And when you see hepatitis B envelope antigen in blood, it means that the patient is currently infected and he is active. The hepatitis is very active and the patient is highly ineffective. Is it clear? So when you see also the hepatitis B core antibody immunoglobulin, it means that there is current infection. Is it clear? The core, you need to know the core immunoglobulins are going to be mostly divided into two. You have the IgM core immunoglobulin and you have the IgG core immunoglobulin. The IgM core immunoglobulin is just to tell you that it's a core infection. Is it clear? While the IgG core immunoglobulins mean that it is a passive infection. Is it clear? So when you see hepatitis B surface immunoglobulins, when you see hepatitis E surface immunoglobulin, and you see hepatitis C B surface core immunoglobulins, so it just tell you that what this is a previous infection. So when the patient has all this in his blood, it means that the patient had hepatitis before and is completely treated. Now for hepatitis C, to make a diagnosis, you just have hepatitis C antibodies which is found in the blood, and you have hepatitis C virus antigen by PCR. For toxic hepatitis, so you need to know the liver is a site of metabolism of most drugs. Is it clear? When you take certain drugs, like toxic hepatitis can occur when you take excessive alcohol or paracetamol, and it's going to also in case of intrahepatic cholestasis. Now, one syndrome in which the drugs may be implicated is the Rey syndrome, where you are going to have an acute disorder which of unknown etiology in children. Usually, when you have a viral infection in children, and then the children take aspirin, so the drug usually like salicylate, like aspirin, a viral infection, the patient is going to have this Rey syndrome, and now it's going to be characterized by enlarged liver with fatty changes, characterized by encephalopathy, like hepatic encephalopathy due to hyperamenorrhea, and ammonia. Is characterized by elevated transaminase and has a high mortality. Now for the intrahepatic cholestasis, you need to know the causes can be the drugs, it can be pregnancy, or it can be recurrent, it can be benign recurrent intrahepatic cholestasis. Now the biochemical features, as I've said, you have high level of conjugated bilirubin, you have like high level of alkaline phosphatase and gamma glutamate transferase, and you have low level of no urobilinogen. So chronic hepatitis and chronic liver disease. In chronic hepatitis, it can be divided into in chronic persistent hepatitis, it can be have mildly elevated transaminase. Generally, the transaminases are not going to be very elevated because it's not an acute inflammation. Those transaminases are acute inflammatory markers. So those, you can have also a chronic active hepatitis. You can have autoimmune disorders which can result to that. Is it clear? May be associated with autoimmune disorders like thyroiditis, arthritis, and colitis. You can have episodes of cell necrosis also relating to cirrhosis. So these are all the different outcomes that you have in this patient. It can be chronic persistent hepatitis, mild elevated transaminases, it can be chronic active hepatitis, it can be autoimmune, associated with autoimmune disorder. You can have episode of cell necrosis leading to liver cirrhosis, and you can have elevated serum IgG, smooth muscle antibodies, and anti-nuclear factors. characteristic. Now we have the next one is alcoholic liver disease. So the biochemical change alcoholic liver disease is that the hazard is going to be greater than the alert. In that ratio, the ratio of the hazard greater than alert is going to be greater than 1, or the contrary is less than 1. So it's a mild. So you are going to have also raised gamma glutamine transferase, and then the other element of cholestasis, which are alkaline phosphatases, are going to be low, and you also have mild disease. So in this patient you can have cirrhosis, and the cirrhosis is characterized by hyperlipidemia and increase in immunoglobulins. Now in non-alcoholic, like example a steato, due to fatty liver disease, steatotic liver disease. In steatotic liver disease, as shown in patients that have obesity, that have known independent diabetes, insulin independent diabetes mellitus, in jejunal ileal bypass, in small bowel resection and other. And generally the biochemical finding is that the alert is going to be greater than the hazard. We have also hyperlipidemia in this patient, and generally in this patient we have non-insulin dependent diabetes mellitus. And then lastly we have liver cirrhosis. In liver cirrhosis, you need to know that it's abnormal activation of the liver. We have fibrosis, we have regenerating nodules, and occurring alcoholic cardiac cirrhosis, and also macronodular. These are the different causes of liver cirrhosis. It can be pre-hepatic, intrahepatic, or post-hepatic. So when it is pre-hepatic, it can be due to alcohol, methotrexate, and all that. Intrahepatic can be due to hepatitis C, B, and schistosomia. Autosomal is pre-hepatic. We have chronic active hepatitis, primary biliary cirrhosis, and all that. Now these are different things to visualize here, and the chemical factors to visualize in a patient with liver cirrhosis are going to be jaundice, you're going to have elevated liver enzymes, you're going to have hepatic encephalopathy because of the ammonia, you're going to have bleeding tendency because of low proton time, you're going to have anemia because of the increased bleeding tendency, you have endocrine changes, you have malnutrition, and it can also convert to hepatic carcinoma. So for me, we say thanks and kind attention. Please don't forget to like and subscribe for our channel, Enzyme Makers. Thank you.